gonna start with we're gonna start with what is family medicine. We're having four amazing, great speakers, each individual one amazing at their own field and their own careers. We're so thankful for the time that they have put in to help us, build our futures. I'm gonna start by introducing Dr. Roshni Jha Ganguly, who is going to take up the first lecture. She herself is an icon. She is the founder and chief of Aswin's Care Clinics, as well as Project Setu Foundation Trust. She is also the chair of AFPI Continuous Professional Development and a member at Large Wonga South Asia region, as well as Royal College of General Practitioners UK and South Asia Board, as well as OSCE Lead India. Thank you, ma'am. We're really thankful for your time. We're really thankful for your guidance and for your knowledge. And the floor is yours.
Thank you so much, Yashri. And good evening to everyone. And I welcome you to this webinar on Introduction to Family Medicine. And as you mentioned that you have a long standing with the Academy of Family Physicians of India, so I would directly dive into the topic. And I want you all to picture this. Just imagine a doctor who cares for you from childhood to your old age. A doctor who treats not only your disease, but treats the whole person, who knows your family, your community, and your health journey. That is exactly what is the essence of family medicine. And today we are here to know in detail what is family medicine and how it makes a lasting impact. So moving on to the slides, shall I share my slides, please? Okay. So why does family medicine really matter? If you look at the picture over here, you see an elephant. There are different people around the elephant, all blindfolded. So somebody touches the ear and says, oh, it's a fan. Somebody touches the tusks and says, it's a spear. Some says, oh, it might be a tree touching the legs. And some touching its tail says a rope. So you can see the varied aspects, when the health systems struggle with fragmentation, that is how we look at it. But when it comes to family medicine, it provides comprehensive, continuous, patient-centered medicine, which is indeed the backbone of the health system. Now, these are few pictures depicting that this is a specialty that provides a holistic, continuous care of individuals, and you can see the doctors across the age groups. From womb to tomb care is what we say. Now, this is a very important slide. Now, this is the Wonka tree. Now, by Wonka, I mean it is the World Organization of Family Doctors. And in the Swiss College of Primary Care, basically the European definition of family medicine, if you see the tree, now it has a foundation of One Health, planetary health, and sustainability. That means One Health means health for all without any discrimination. Planetary health is keeping in mind our environment, and sustainability is how we sustain each of this, integrating all of this together. There are 6 core competencies of a family doctor. That is, they need to provide person-centered care, community orientation. If you know your patient, you know the person within the patient, and you know the community. What are the diseases prevalent? What is the community behaving like? So community orientation is important. Specific problem-solving skills. So it is not just about case study and just picking up the problems and you give medications. It is about how you solve these problems, keeping in mind the context from which the patient appears. Comprehensive approach, meaning the holistic approach, primary care management, and holistic modeling. So these are the core competencies which we are looking at, and we have 12 attributes which arise from these core competencies, meaning that what will you get out of it? You will get doctor-patient relationship on basis of trust. You will have patient-centered care. Again, it depends on the context, the ideas, the concerns of the patient, and how you integrate it into your problem list. Promotes empowerment. That is so much important. You empower the patient, you give the autonomy to the patient to decide, and you have a shared decision about the treatment or the management. Responsible for the health of the community, not only the patient, but you're looking at every consultation as an opportunity to see the perspective from the community to provide opportunistic health promotion. So decision making based on incidence and prevalence, very important. Early undifferentiated stages. More often than not, we see that when a patient first comes to you, they have an uncertainty in the sense at the first consultation, you may have various differentials running in your mind, but there are very few cases where you might just be having one spot diagnosis. You may have multiple problems and you need to navigate around those problems to come to a conclusion. On the other hand, we have acute and chronic health problems, which we must deal with. Promotes health and well-being, definitely. Care coordination. So when you have care coordination, meaning that you are seeing the patient, can we just mute the mic, please? Thank you. Care coordination and advocacy means how you are going to place yourself in the whole health system. And for example, you are the first point of contact for all health concerns. You are caring for all age groups and you're focusing on prevention and acute and chronic management of disease. At the same time, if you have to refer a patient for higher treatment, for example, a surgery or a procedure, or any other treatment, then how you coordinate that care within your health system is something that you need to be adept at. First contact, open access, all health problems. So you are the gatekeeper. The patient comes to you first. So the width of your knowledge, the width of the patients that you see is much more than any other specialty. And it encompasses not only physical, but psychological, social, cultural, and existential components of healthcare. Okay. Now let's begin with a case story to give you a perspective to understand how we've woven the principles of family medicine into this case story. It can be very many case stories. We've taken one example. So let's look at Mr. Ramesh or Mr. XYZ, whoever, 55-year-old gentleman who lives in a rural village in Madhya Pradesh. He has low back pain for the past 2 months. Now he has presented or he's come to the clinic with persistent low back pain, gradually worsening over the past 2 months. He describes the pain as dull and aching, increased by prolonged standing and physical activity. There was no history of any trauma or recent infections. Many of you, this might sound very familiar when you're presenting your history in your wards. Going on to the past medical history, he has diabetes for the past 5 years and high blood pressure for the past 8 years on regular medications. Coming on to the family and social history, he lives with his wife and daughter in a rural village and he's a farmer. His lifestyle is very physically demanding, as is for many farmers, that they have to be very active when they're sowing, reaping the crops and all of that. So they are always on the go. But here we have some financial constraints which prevent him to seek timely medical care. He reported feeling of increased stress due to these economic pressures and is concerned about his family's future. Okay. Moving on to the examination, you have the vitals given here: blood pressure 140/90, heart rate or pulse rate of 78 beats per minute, regular, respiratory rate 18, SpO2 98%, general examination all fine. There is mild tenderness in the lower lumbar region, normal range of motion with mild discomfort. Neurological examination, cardiovascular, respiratory examinations all have normal findings. Now, going back to this case, if you see the way you take your history in your medical college is that you know the name, the age, the chief complaint the patient has come with. You probe more into the history of the patient. Then you come to the medical past history, social history, family history, drug history, or menstrual history in cases of women, and you move on to your examination and come to a differential diagnosis. But here, when we see, we've provided a little extra information that, okay, the socio-economic aspect, that he lives in a rural village, he's a farmer, he has to be active, he lives with his wife and daughter, he's concerned about the family's future because of the economic constraints. So how does all this fit into the whole weave from a family medicine or a family physician's perspective? Now, if you see the 9 principles of family medicine, so provides comprehensive care. So we are seeing this person as a complete whole person. So we've seen his history, we've seen what his medical examination is, we've seen his past history and how it can be related to his back pain. Continuity of care. Now, you have been seeing Mr. Sharma and you know what kind of a lifestyle he leads. What is it active? What kind of mental health parameters that he has? That, what is he going through? Is he going through stress? And that can only happen when you are in close contact with the patient. You know about the history, you know about the family. Personalized care. So you recognize this stress as a contributing factor and you may offer mental health support or counseling using a family-centered approach. So you're also thinking about the whole family, the lifestyle changes that he is concerned about, his wife and daughter, and the future of the family. Preventive care, in this case, because he is diabetic, he is hypertensive, you may encourage vaccinations like the influenza vaccine, the pneumococcal vaccine. You may also think of the tetanus booster dose vaccine, diet modifications, exercise. So this is encompassing not only the problem he's come with, but you're taking this opportunistic health promotion method over here, acting as a gatekeeper. Now, in case the back pain you've initially treated and you think there is a radiculopathy there, he may need a higher center referral, he may need the opinion of a neurologist just in case. In this case, it may not be. Then you are the gatekeeper and you have to do that referral. Community oriented. So you, as a family physician, may opt to do a health camp for diabetes screening when you have identified so many diabetes patients, for example, in that particular village, and how you would help. Prioritizing holistic health, and you advocate equity in health. So you are providing the same treatment regardless of his financial status. So we can see here that the impact of family medicine. So this case particularly is highlighting, please note the words, integrated patient-centered approach that family medicine offers, ensuring holistic and continuous care. And it's much beyond the symptom per se. By addressing this physical, psychological, social determinants of health, primary healthcare and universal coverage, particularly in resource-limited settings. So this is what this case is depicting. And this is what family medicine is all about. So last one point I would like to mention, that what is family medicine's role in universal health coverage in health systems. There has been global evidence that it definitely improves access to care, reduces healthcare costs, strengthens community health, reduces hospital admissions, and countries with strong primary healthcare systems have definitely had better health outcomes and lower health costs. Okay. So here we are today as a team to encourage you to join this movement, join our team, because the key takeaway today is that a well-trained family practitioner can manage most of the problems that most people have most of the time. Okay. So we encourage you to join this specialty and serve your country. And trust me, there's no more satisfaction than serving your country with this holistic care support. Thank you very much for a patient reading. And one textbook that I would encourage you to read is by
प्लीज भी तुम लाइट ऑफ
Ian
करके
Wakening,
जाना, ये लोग अगर मैं कब तक
and
इधर बैठूंगा ना,
and
ये लोग
Textbook of Family Medicine by
लेके
Ian
मेरे को
McWhinney. Right? On that
दे
note,
दो,
thank you
सबको
so
फिर
much
से
for
दे
your
दो,
patient hearing,
इसलिए
and we
ज्यादा
move
इनका
on to
इधर
the
नहीं
next
रुकना
topic.
ये लोग को.
Can we please mute the mic, please? Thank you.
Thank you, ma'am. That was such a good introduction to family medicine. Next, we have Scope and Career Pathways by Dr. Rashmi Taimul. She herself is another icon that we have today, and she's gracing us with her presence. She is the head of Department of Family Medicine at Lord's Hospital, Postgraduate Institute of Medical Sciences and Research, Kochi. She has achieved certificate in Essentials of Palliative Care, postgraduate diploma in geriatrics with a DNB in family medicine. A lot of feathers in the hat, I would say. Apart from that, she has also been the General Secretary for AFPI, and in the past, she has been National Treasurer as well as past President for AFPI Kerala. She has been the organizing chairperson for FMPC 2017 as well as an AFPI member of the year 2017. Many publications in index journals, and she has been a faculty in various national and state conferences. Thank you, ma'am, for gracing us with your presence, and the floor is yours.
Evening all. Hope I'm audible. So
Yes,
thank
you
you
are.
for that introduction. Thank you for that introduction with a few corrections from my side, which I think would be that corrections will make you understand more what family medicine is. It is not community medicine. Family medicine is a different branch. That is one thing. And FMPC is the Family Medicine and Primary Care Conference that happens, the national conference. Okay. So this is not a correction. You can always join FMPCs also in future. So I need to speak about the scope and career prospects of family medicine. So can I ask somebody to share in the chat box what is the best specialty that you need? What is the best specialty? Which is the best specialty? Many of you would have started your clinics, so you'd be thinking of doing post-graduation in some specialty or the other. So what do you think is the best specialty? 30 seconds for somebody to type in the nuclear medicine. Okay, fine. Then only nuclear medicine, no one else has any other options. Biochemistry, okay. The same person has two best specialties. General surgery, okay. So I'm not wasting much time. So do you think there is something called as a best specialty? Do you think there is something called as a best specialty? Every field of medicine is very important, and you have to choose a specialty that is best for you. It is not something that is best for you may not be best for someone else. So how do you decide about family medicine? That's what I'm going to say, because I know that 99.9% of you are not exposed to family medicine in your undergraduate curriculum, very few medical colleges have family medicine. So without knowing what it is, you cannot commit on whether it is a good specialty or good for you or not. So now I will share my PowerPoint presentation, but this PowerPoint presentation may not cover everything, but let me do it. So this is the thing I want to tell you, that family medicine, as Dr. Roshni clearly said, it is one for all. It is one specialty that can treat anyone to some extent. So it is a one for all specialty. So how do you decide about family medicine? This is something that circulates in WhatsApp groups, but not a joke. When you join medicine, when you are into your final year, you are having so many, you are exposed to all the specialties. Then how do you select a specialty that is best for you? How do you decide what is best for you? What is your strength and what is your weakness? So if you like everything, what do you do? That is the confusion. When you like everything, you can take family medicine. There is no looking back. You can just go ahead and take family medicine, because if you like adults, you can take general medicine. If you like some blood and knives and everything, you can take general surgery. If you like women, treating women, you can take obs and gynecology. If you like children, you can take pediatrics. But if you like everyone, if you like everything, what do you take? You take family medicine. Again, the same thing in a different flowchart thing. So what do you can, this comes as humor, but this is actually very relevant. So if you like everything and you like to know about people's mental health, you like to know the public health problems they are facing, you like to do a bit of procedures, but not in the OT. You want to see women, but you are not wanting to limit yourself to treating women. You like children, but you don't want to limit yourself to treating children. You can take them. Okay. So this is it. But we are not the jack of all trades and master of none. We are jack of all trades and master of many. Okay. So this is the difference between family physician and a single system specialist. We exclude the presence of serious disease, that is through red flags and yellow flags. That is one of the main concepts of family medicine. That is, when you see a patient as a whole, you decide whether there are some red flags that point to something serious in this patient, something very serious in this patient. And if so, you have to deal with it accordingly. If not, you will deal with it in a different way. A single system specialist confirms the presence of serious disease. So, for example, if you have a headache and you go to in our country, what happens is you have a headache, you Google it and you find that seems you have a brain tumor. So you go and see a neurologist. And what happens is the neurologist does all sorts of tests, because he is trained to decide whether it is a neurological problem or not. So he or she does every clinical examination pertaining to neurology and the investigations, and finally decides that this is either a neurological problem or not. So what happens if it is not a neurological problem? Where do you go? Then you Google again and find that it can be due to sinusitis. Then go to an ENT doctor. The ENT doctor says, no, it's not sinusitis. Then you Google again, you find that it can be due to tooth problems. You go to a dentist. You go to an ophthalmologist. You mean the patient goes to every doctor day by day, and his days of work is being cut, his salary is being cut, his time is precious time and money is being wasted. So if he had gone to a qualified family medicine person, a family physician, the doctor would have looked at him as a whole and decided what is his problem and found out what is his problem, and if needed will treat himself, or if It is something serious that needs a further another specialty consultation would refer to another specialty. And family physician tolerates uncertainty, managing patients with undifferentiated symptoms, as Dr. Roshni already mentioned. A person comes with undifferentiated symptoms, and you can you try to solve it in the best possible way. So you need a bit of, a bit of intuition, a bit of common sense, and a lot of clinical knowledge too. It is not that you are just a talking person or a communication person. No, you are not. You are neither a police man directing to different specialities or a traffic person directing to different specialities. You have to see a patient with uncertainty and decide. And you have to explore probability of seeing patients from a population with a low incidence of serious disease. You're seeing a population, you are connected to many people, and you have to filter what sort of patients might have a serious disease and who might not have. And you have to marginalize danger. So that is where the red flag signs come in. So one concept is resolve more and refer less. You can resolve whatever you can refer, and whatever is demanding further specialty care, different specialty care, you refer. So all these things Dr. Roshni has already mentioned. So this also Dr. Roshni already mentioned as principles of family medicine, an open-ended commitment to patients. That is, it's not ending with one disease or one particular point of time. You see patient in a continuity, and you understand the context of the illness. You use all your visits for preventive purposes too. The patient may be seeing you for something else, and you find that he is a smoker. So you can educate him about the hazards of smoking too. You're not just looking at his person with CAD goes to a coronary problem goes to a cardiologist, and the cardiologist suggests the treatment for that. But who will prevent him from? Who will tell him that it was the smoking that caused it, and who will educate him about the adverse effects of smoking, and who will follow up him for his smoking habit? That also has to be done by a family physician, because the cardiologists are busy and they have much better things to do. They have interventions to do. They don't have time to educate the patient about this. View of the practice as a population at risk, as already mentioned. That is, when you see a patient, you know that this disease is there in the population, and the population is also at risk, and you have to educate the population also, do preventive services to the population also. Use of a community-wide network of supports. You should know where the patient can be directed to. If you know that this patient is alcoholic, and you know of some support group that can help him in reducing this habit, you can send the patient to that. Sharing of the same habitat as patients. If you are in the community with that of the patient, you can know what are the problems, the social and cultural factors affecting it. You care the patients not only at home, not only at hospital, you care for them at home also. You go for home visits. You see the patient at homes, and so you will have a better connection with them. And most of the patients who come to hospitals are different persons when you see them at home. Only when you see at home, you know what the real picture is. Recognition of the subjective aspects of medicine, not the objective examination findings only. Awareness of the need to manage resources. What is necessary for one person and what is not necessary for that. That is how you manage resources. So in the training, you are made a medical expert. You are stressed on the doctor-patient relationship. You are a collaborator, manager, health educate, lifelong learner. You have to learn about good medical practice and care, professional, ethical, and legal obligations you will go through, and you have to work with a team. You are a team leader also. So there are so many postgraduate courses in family medicine, like the MD in family medicine. I have mentioned only a few. There are the new aims have many new aims have started. Only family medicine MD. Previously, it was community and family medicine MD aims. There are so many only government medical colleges that at Calicut, Kozhikode, Kerala. Then PMC Vellore, St. John's, NRI Medical College. Now, recently, a private medical college in Kerala also has started MD in family medicine. There are so many DNB family medicine seats under the National Board of Education and Medical Sciences, NBEMS, and they have also started diploma in family medicine. There are other courses like PGDFM, MEd, and diploma in family medicine by various institutions, including the prestigious one from CMC Vellore and other certificate courses also. So this is the doubt. What is the difference between family medicine and internal or general medicine? What is the difference between family medicine and community medicine? General medicine or internal medicine deals with holistic care. That is, it is mostly caring the patient who are inpatients. Hospitalist medicine rather than an outpatient setting in a medical in a community. Also, general medicine can handle medical problems in adults. Medical problems in adults, not in children, and not a minor surgical problem, not gynecological problems. So the family medicine is a much broader or a generalist concept than the general medicine or internal medicine. Now, what about community medicine? Community medicine is mostly focusing on the population, not on an individual. And it is mostly not clinically, clinical speciality. It is mostly on developing policies. You do research, you study populations and develop policies rather than concentrating on a personalized care for a patient. So, what are the ideas, concerns, and expectations regarding family medicine? What is your idea about family medicine? I hope so far I have cleared some of the ideas. And what are the concerns? You might have so many concerns. What will happen when I take this PG as a specialty, this specialty as a PG, and how will be my career like? And what are your expectations regarding that? That all decides whether you select family medicine or not. Role models are very important, and as many medical colleges don't have family medicine persons, I hope this is the first time. I think this is the first time that you are seeing some family medicine persons in flesh and blood. Maybe if you come and attend our conferences, you can see there are many more family medicine persons alive in India. So previously, you must be thinking that you would not have seen many. Sometimes what drives us to take a specialty is the personality of the teacher. You take general surgery because your general surgery HOD is a very good clinician, a very good surgeon. Sometimes you take general medicine because you have seen so many other postgraduates and professors in general medicine who are very good clinicians, but you have not seen any role model in family medicine. That is the issue why so many people are reluctant to take family medicine. So to have more role models in family medicine, we always propose to have family medicine in the undergraduate curriculum as well as introducing more PG seats in family. Professional groups like so far your group is also one such, and there are professional groups of doctors like the IMA and service associations which can help in educating people about family medicine, educating the medical fraternity about family. Social media, of course, social media in these days play a big role in deciding what specialty you take. And other specialities, you weigh your pros and cons with other specialities to decide whether you should take family medicine. So you research extensively. That's what I would advise everyone. When you take a specialty, you research extensively about that. It is not about the 3 years of training. It's about a lifetime of choice of a lifetime. So you have to choose wisely. Finance, salary, I can guarantee you that it is at par with any other specialty in any city or town you take. When you compare the salary of a family medicine person with that of a general medicine person in that area with that much experience only, it is really comparable. You should not compare with people in other cities or other rural areas or those with other years of experience. Family and social life, of course, I can guarantee you that it is the best. Like a senior professor who used to call me during a national conference that we conducted, every time he calls me, I'm in the movie theater. So he asked me, the moment he calls me, he asked me, Dr. Reshmi, which movie are you watching now? Which theater are you in now? So that is the type of social life or family life we have. We can always dedicate to our interests, hobbies and interests. I know Dr. Roshni has so many interests, outside family medicine. She's a good singer, and other interests too. Dr. Jyotika and Dr. Gunjan, who are also part of this panel, they all have varied interests in life, and they all have the time to pursue that also. That is what is great about family medicine. We have families, we are managing families also with that. So you can always decide your practice time, your OP time, the time you spent with your patients and the time you spent with your family and your other interests. So opportunity is always ahead of you. You can run, the most satisfying thing is you can run your own clinic. In India, the opportunities are like that. You can run your own clinic. You don't need an ultrasound machine, MRI machine, ECG machine, nothing. You just need yourself and maybe a BP apparatus, a thermometer, a weighing machine. That's enough to start a clinic. You can have some attachment with some connection with some lab or pharmacy nearby, and you can start your own clinic. You don't need so much of paraphernalia or so many instruments to start your own clinic. That is the best part of family medicine. A cardiologist starting his own practice cannot afford to start without an ECG machine nearby. A neurologist cannot, in this era, cannot start a practice without having an MRI or CT facility nearby. But you can, if you are a family medicine specialist. Group practice, of course, if you don't want to spend 24 hours, 24/7 in your clinic, you can have a group practice. Similar minded family physicians, you can rotate your practice. You can do a group practice also. Polyclinic. Polyclinics are coming up in India. There are many polyclinics coming up. You can be the primary care physician there, a family physician there, and other specialty or subspecialty consultants can come in as and when you refer patients or as and when you select patients for being seen by them. So that is one opportunity. Secondary level private hospitals, definitely you can sort you can be a substitute for general medicine, pediatrics, OBG, everything together in a secondary level private hospital. Tertiary hospitals, you might think that this is a paradox, but of course you can direct patients who like we said before, who have a confusing symptoms or who doesn't have a particular symptom, who have a mix of symptoms, undifferentiated symptoms, you can sort out them and if needed, refer to the concerned subspecialist. Or you can even be a coordinator of care. You can be a communication between the patient and the other subspecialist. So many things you can do in a tertiary care hospital also. Academic institutions like where I work, where there is a training in family medicine, of course, that is another opportunity. Government services, PHC, FHC, and CHC, government is working on creating specialty cadre. But even without a specialty cadre, if you are a family medicine person, you are the best suited to work in a primary health center or a family health center or a community health center because you have the expertise. After your family medicine training, you have the expertise to see these patients. It is saddening to see that sometimes somebody who has done an ENT or ophthalmology PG, once they enter the government cadre, the entry cadre is like you have to see everything. And they are at a loss because they have not been in contact with all patients in the last 3 years when they did a PG. So you are the best suited in that position also. Hopefully AFPI has been working for this with the NMC and with the government sector in different states also to introduce a separate specialty cadre also. Hopefully that will come soon. Central government agencies like the CGHS all have everywhere. You have so much of opportunity to do. You are best suited to work in a primary care or a community health center type of facility. Abroad, of course, you can do MRCGP International to work in South Asian countries, FRA-CGP, which is Australian, USMLE, you all know, for USA. In USA, Canada, Australia, UK, and the Middle East, family medicine is much recognized than in India. If I tell my personal story, once I decided to take family medicine, all my relatives were apprehensive. What is this family medicine? Nobody knows about it. There are so many doubts about why are you taking family medicine. So my brother who is in the US said that That is the most sought after specialty in the US. And then everyone was happy. Yeah, this is something sought after. But in India, it's not so. So those who are planning to go abroad also, there is a big scope for family medicine abroad. So it's awesome. That's what I have to say. It's a smart career choice. If you have any questions, I'm ready to take that. Thank you so much.
Thank you, ma'am. It was a really good experience listening to you and knowing our scope in family medicine, as it is an upcoming branch which has a good work life balance. And like you said, from child to adulthood to everything, family medicine covers it all. Next, we have Dr. Gunjan Shah. Yeah, she's going to cover common myths and misconceptions about family medicine. I would give a brief introduction about Dr. Gunjan. She is a consultant family physician and chair of Spice Root India, very dynamic and very dedicated. She did her MBBS and DNB family medicine, MBBS from Ranchi University and DNB from Fortis Hospital, Noida. She is currently the director and consultant physician at Pursuit of Health Clinic, Indirapuram. Her journey in the world of family medicine started in 2019 when she joined AFPI and Spice Root India Movement India. In 2020, she was the lead of Delhi State Chapter for Spice Root India Movement. In 2022, she was the member of National Council of Spice Root India Movement as a treasurer. In 2023, she became a member of Wonka Working Party on Women and Family Medicine. She also was a part of Young Doctor Lead for WW, the PWFM, as well as she is from 2024 to 2026 National Chair for Spice Root India Movement. While holding all above amazing mentioned positions, she has also coordinated multiple case presentation sessions, meet and greet sessions. She has also coordinated Delhi State FPCon in May 2024. She is also the active member of Spice Root South Asian region. Thank you, ma'am. The floor is yours.
Thank you for such an elaborate introduction. Hello, all young residents right now. Future seems very tricky and it's very difficult to make a decision where you are right now. You have very little exposure of what future branches hold for you. Being confused about any branch is pretty normal, but you have to understand something. Any clinical branch is going to offer you the ability to practice, and your ability to practice well decides how much you're going to earn, what kind of work life balance you can have. I was just going through the kind of questions you guys had put up, and the previous two discussions have definitely cleared up a lot of things. Still, I'm seeing in chat you are discussing about family medicine being similar to PSM or similar to MBBS. During MBBS, you have such a long time learning theory and practicals about everything. But having 3 focused years for any residency sharpens your clinical skills. PSM is focused more about the preventive aspect of diseases, and family medicine is more about the application of your clinical skills towards all age group from newborn till elderly. So definitely there is a difference, and you appreciate the difference when you see these branches around you. When we discuss about the future of these branches, within 10 to 15 years, we expect all medical colleges to have a separate family medicine department. In the Western countries, they focus upon having at least 50% of their clinical branches, the PG branches, to be family medicine. That increases a good quality healthcare workers in society. To have a healthy India, that is only way we can achieve it. And when you have such a big department, such big numbers of these branches, you guys would be in practice at that time. You would be there, fresh, available with your degrees. So when you want to know the future of this branch, this is what you are focusing upon. Few decades ago, radiology was considered as the technician's job, and people didn't want to pick up that. Surgery, obs gynae, medicine, these have been evergreen branches. But right now, you see how radiology is the topmost branch being picked up by the toppers. So, perception of people keeps changing. This is where you understand that any myth should not be taken to heart. What you prefer, what kind of branch you like, should be the sole deciding factor. And many students do not have clarity about which branch they want to pick up. But you have to have some clarity as where you want to see yourself in 10-15 years. If you see yourself practicing as a doctor, having a clinical branch, then family medicine gives you the expertise. There you can choose whether you want to have only medicinal branches, you want to do any surgery or not. That option is open only for a family medicine resident, not for other branches where they have to stick to their department, as well as they cannot jump from medicinal to a surgical branch that swiftly. Also, a lot of clinicians at some point of their life feel saturated by the kind of cases they are seeing. But a family physician has such wide spectrum of diseases, that is a great plus point. You will never feel saturated by the same kind of cases or getting out of touch with basics because you're forgetting some of the very common diseases. One very prominent example I had seen, and I would like to share that with you. A young male patient had come with severe pain in right epigastric region to a physician, and physician advised antibiotics, painkillers, referred to a surgeon. Surgeon assumed it to be gallbladder stone, referred for ultrasound. The radiologist saw that the region was reddish, some lesions were developing, and the patient was saying it's severe pain is there. So the radiologist referred to an anesthetist, pain medicine specialist. That doctor referred to a dermatologist because the lesions were not explaining the pain, and the dermatologist finally diagnosed it to be shingles. So you see how the patient moved from multiple departments. While this could have been diagnosed with a proper examination, that I agree, but single doctor understanding all components is important. After 10-15 years of practice, you stop noticing symptoms as a doctor and only focus about your branch point of view. And that needs to be diluted in today's era. A doctor has to understand all aspects of a disease. Only then the patient will recover completely. Most of your questions, like difference between different types of general medicine, internal medicine, and family medicine, that being similar to MBBS, or job security and future work-life balance, has been discussed adequately. And the job profile and stuff is this dear, that any kind of work-life balance can be achieved only when you are your boss. And mostly a job in medical college or a corporate job will keep you binded by their rules and regulations. You'll always be dependent on them. The sooner you can start your own setup, only then you can have your peace of mind. The best kind of financial security is only in your own setup, and of course the work-life balance as well. And this opportunity is finest with family medicine. I hope that gives clarity to a lot of questions you had asked. The portal to asking questions is open. This link between AFPI, Spice Route, and MSAI is open for further discussions as well. I would request that now you move on to our next speaker for the next aspect of today's discussion. Thank you.
Thank you very much, ma'am. That was wonderful. Before I introduce our next speaker, I just want to remind you, like ma'am said, keep asking questions, keep putting them in the group chat. If time permits, we'll take them one by one. No worries. Our next speaker is Dr. Jyotika, and she's going to be telling us about a very wonderful topic, that is a day in the life of a family physician. Dr. Jyotika Gupta is also a consultant family physician and leading the services at RxTX. She's an executive member of AFPI and advisor to Spice Route India. We also have an introductory video for all of you to see. So here it is.
Sorry, I lost you in the end.
Am I audible?
Yeah.
Okay. I'm sorry. Okay, I'll share the screen. Okay.
Can I
Just a
start?
minute.
Yeah. Can I start?
Just a minute. I'll just share the screen.
Share the screen for the video that I shared?
Yes.
Yeah, so I'll just talk about that and then you can play the video.
Okay. Yeah.
Yeah.
Go ahead.
So, good evening, everyone. Lot has been spoken about family medicine, and we are constantly chatting in the chat box as well. And honestly speaking, these are the questions we all have been dealing with for the past 10 odd years, that MBBS is equal to family medicine, and it's same like community medicine. It's like a what glorified internship. This is something we hear every day in and out, because you think that it is managing multiple departments. What you don't realize is that going into one single specialty will narrow down your thought process as well. Whereas when we are family medicine specialists, we have a huge variety. So it is more of width than depth. So my topic, of course, is a day in the life of a family physician, which is a very, very interesting thing. And I think last to last year, I had actually got this video made at my clinic, because this was, of course, for the public, but it really makes sense that we show even our MBBS graduates that what exactly is the life in a day of a family physician, which will give you that huge variety of cases that we see. No two patients are similar, unlike any so-called super specialty, which is the only term used in India. But you have those specialists like cardiologists, gastroenterologists. Gradually, when you go up the ladder and you meet them, you will realize surgeons, gastroenterologists, they have those set of 10-20 investigations and 10-20 medicines. Beyond that, they cannot think, and then the patient is referred. So a pregnant lady who is diabetic, who may have some gastritis, will end up going to 4 doctors in a day: a gynecologist, a diabetologist, and a gastroenterologist. Whereas a family physician can treat her A to Z at home without having her to run around. So yes, Yashri, I would request you to play the video, and after that, I'll show how, what is, the variety with which we function each day.
क्या हुआ है? मेरे को इधर दर्द होता है, इधर दर्द होता है, और मशीन में भी बहुत दर्द होता है। खाने का हजम नहीं होता है, पेट में भी बहुत दर्द होता है, यूरिन में तकलीफ होती है। मैं चेकअप कर लूं? हाँ, चेकअप करती हूँ। दवा लिख कर दूंगी। अच्छा, ठीक है। हाँ।
Thank you so much. So, this was a little glimpse in how we all function each day. And, my previous speaker, Dr. Gunjan, is currently in the OPD. And no two patients that we see back to back are going to be similar. So, the small video that I played, you see that we can see medical cases, whether it's pain, abdomen, fever, nausea, vomiting in a regular 30-year-old, 40-year-old. We do house visits on a regular basis. So we can address the healthcare of all elderly patients. And we know that India is going to face a huge chunk of geriatric population who will be needing a lot of medical care. So a family physician is the one who's going to go home and give them care. Your super specialist is not going to enter their home, because they are going to be sitting in their hospitals. They are not going to actually patient at home. Then we can deal with small injuries and wounds. Actually, a lot of my colleagues even do small procedures. I don't do it as frequently, but we are all capable of doing it. And finally, I showed you a glimpse of a daycare patient. That was a real patient. She was getting IV iron, and I had taken the consent from her to actually shoot that. So her face is not visible. But what I'm trying to say is that you saw OPD cases, you saw home visit, you saw an IP or a daycare, and even surgical. This is just the tip of the iceberg. We can deal with many, many, many such cases on a daily basis, and it's never a boring day in our practice, and it's never monotonous. The moment we start to think, okay, this is so simple, it's just a viral fever, we will get bombarded with something which is going to completely take us off the board. And uh, slowly and gradually, and of course with our efforts, say with Dr. Reshmi, she's a head of the department in the hospital, and Dr. Roshni is in a private setup. I used to be in a corporate setup, now I am in a clinic. We have also made that little bit of system where the specialists like surgeons or orthopedicians or gynecologists, they are happy to refer the patients back to us after surgery or pre-surgical assessment. So they know that the whole circle of care will be completed by us. In reality, if once a surgeon has completed surgery, uh, the kind of follow up done, we all know how it is. But now, with most of our efforts, our colleagues are happy to send the patients to us that yes, you will counsel well, you will guide them well, and you will take care of them, and their headache is gone because surgery is done. After that, they'll have doubts like, can I eat apple? Can I eat rice? Can I have buttermilk? Can I eat this? Can I walk? So all that is actually dealt by a family physician. So I think the variety that family physicians can see and address cannot really be addressed by anyone else. I mean, I can vouch for that. So thank you for this opportunity, and we would love to have you at our conference. We would love to have you at our clinics. We are ready to host you at our clinics to do exchange programs, to do visits, so that you actually understand what all we deal with. And we have people in institutes, we have people all over India, of course. We have people in institutes, in private clinics, in corporate clinics, in corporate hospitals also. Many of us run many departments, so you can get a huge variety of opportunity to understand. So let's take this forward. Of course, MSAI and AFPI have been associated from a long time. Let's accelerate this. So yeah, let us know various sessions where you could know about us. Come and visit our clinic. That's the easiest. We don't have to, say anything. You can just see hands-on. So thank you very much and all the best. See you at the conference.
Thank you, ma'am. Thank you. And I thank all the speakers for their time, for the efforts that they have put in to explain to us and to open our eyes to family medicine. It has been a huge, huge help, a knowledgeable session, and we would really like to thank you, and we are very grateful for you. The floor is now open for the questions.
Can I answer a question about the training? I mean, somebody has asked about the rotations in family medicine in the chat box, which we have not answered. Can I?
Yes, ma'am. The floor is all yours.
Yeah. So, since I'm in an academic institution, I would like to answer that. We have rotations in all branches, like medicine 6 months, that is internal medicine 6 months, pediatrics 6 months, OBG 6 months, then general surgery 3 months, ENT, ophthalmology, orthopedics, psychiatry, dermatology. If your hospital has a pain and palliative division, that depends on some hospitals which will be specialized in some care, everything else. So I think you've got an idea. And some of the community health centers which are attached to the hospitals, the primary health centers that are attached to each hospital, there also they'll be posted. I mean, in your residency, you would be posted. So it's not a glorified internship. I think that internship most of us do most of the things on a spinal level. Somebody orders us to do something, you do it. You are not doing it understanding the broader aspects of the person or the patient. And you all see patients as cases. So when you start seeing the patient as a person, that is what happens in family medicine. It is not just a mixture of all the specialities. It is the concept itself is different. And to answer somebody who asked, why do you need internship? Why do you need another training once you have done in, MBBS and all this? I have posted the answer also. See, during MBBS, you get training in mostly tertiary care hospitals, which are oriented to tertiary care of patients. You don't see a patient coming with, in your routine OPD, you will never see a patient walking in saying that I have medrestenosis. No. But in medical colleges, you will have that because patient comes referred from somewhere else, and you know that you are going to treat this mitral stenosis. That is the difference. The person might say, I have a chest pain, I have this discomfort starting from this place, going to this place, then in between I have some palpitation, in between I have some chest pain, in between I have some breathing difficulty. So you have to find out what is wrong with the patient. That is the difference. That is the kind of training that you get when you do a 3-year family medicine residency. Rather than in a medical college, you mostly see that patients come referred and you know to some extent what this patient has. When you see a patient in a surgery ward, you know that this is a surgical case. It is not something related to psychiatry or dermatology. But in family medicine OPD, a patient comes and you have to, like Dr. Jyotika said, you have to find out what is it. A cardiologist sees just 5 symptoms in a day. I'm not exaggerating. Chest pain, palpitations, dyspnea, and a few other things. But family physician, you don't know who is walking in next, who is walking in with what symptoms. So that is a kind of training you get in addition to what you did in MD. I hope that is clear.
Thank you,
About the
ma'am.
subspecialties too, the question is whether you want to be a generalist or a subspecialist. If you want to be a subspecialist, family medicine is not the answer to that. If you want to treat everyone, that is where family medicine comes in. And suppose in your area, more women come and you want to get more exposed to problems in women, you can always learn more about that after doing your family medicine. Or suppose you see that in the community that you practice, there are lots of diabetics and you want to learn a little more in detail about diabetes, you can learn always little bit more about diabetes, remaining a generalist. You can remain a generalist and know a little more about whatever is important in the community that you practice. Thank you.
I think it is to do with the special areas of interest also, as Dr. Resmi is saying, because family medicine is the broad specialty. On top of that, whatever others, subspecialty you want to choose, whether it's maternal and child health, whether it is diabetes, etc., you can pursue courses to get a depth of that, depending on what kind of patients you're seeing. But on the whole, as we said, that the width of the specialty is much, much more because you don't know what is your next, patient coming in. If you start with a viral cold and cough, the next patient may be UTI. The third one may come with a trauma in the leg. Fourth one, you may just have to do an incision and drainage. Fifth may be a diabetes patient. So it just varies. So you need to have, and that is done by training. And there is a method of consultation also. Once you acquire the knowledge of the different and go through your 3 years curriculum, then there are consultation skills that are taught to you, that how do you approach the patient. how would you understand how to take care of that whole person, how to, uh, do that holistic care. And there are various consultation models for the same, which can be practiced, where you can find out the problem list, you can find out the hidden agenda, you can find out what the psychosocial problems that could be related to the primary problem. So that gives you the whole picture and helps you to. So that's how it is different from internship. That's how it's different from your MBBS. And yeah. So I think the best opportunity is that one is you keep in touch with AFPI and Spice Route to understand. And if any opportunity across India permits that you want to visit one of our clinics or sit with one of our practitioners, you can get in touch with us through your MSAI leads, and we can help you find out a clinic or maybe have exposure to family medicine. Thank you.
Thank you so much, ma'am, for clearing our doubts. Thank you to help us, build our knowledge on family medicine. Thank you to all the speakers for being here, for giving a precious time, and it has been a pleasure and honor to share this stage with you and be here and learn from you. I would also like to thank all the participants to be here, to listen, to ask questions, to be present in this amazing webinar. Any more questions, you can definitely forward it to our Vice President of External Affairs at vpe@msiindia.org. We have already shared the post webinar form in the group chat, so you can click the link and get it. Fill up the forms so you can get your certificates as well. And thank you everyone once again for such an amazing.
Thank you.